Okay, now we're going to start in on chapter 21 or 51. We're going to start doing diabetes. Although it's just one chapter this week, there is a lot of information, a lot of content, and you really have to have a pretty solid understanding of diabetes, because everybody has this disease in America, and it's increasing in America. So a ton of people have this. And it's essential for you, because no matter what patient population you end up taking care of, you will have a large percentage of your patient base will be diabetic. So you do need to understand diabetes. The lecture component might take a while. So I've decided to break it up into 3 parts so you can kind of take pieces of it. So the first thing that we're going to do in this first lecture is just an overview of diabetes. You need to understand the difference between type 1 and type 2 diabetes. Then in the next video segment we will talk about the treatment, some of the treatments that we do for diabetes. They're different for type 1 and type 2. Some of the drugs in the pharmacy that we use. And then in the third one we'll talk about the complications, because people that have had this disorder for a long time end up having a plethora of complications, and then that sort of becomes a secondary issue that you need to deal with as a nurse, is how to take care of the complications associated with diabetes. So the first thing that I want to point out is basically what is diabetes. So when you need to determine whether your patient has a type 1 or type 2 diabetes, because they are completely separate diseases. They are not the same disease. They both involve the pancreas, glucose, and insulin, but that's about it. Type 1 diabetics, research hasn't shown that there's an exact genetic component yet. They haven't identified a gene that says, oh yeah, you're going to have diabetes, but there does tend to be a familial component to it. So if your grandparents had it, you know, if there's somebody in the family, an immediate family member that has had type 1 diabetes, the chances of subsequent people in that family also having the disease go up compared to a family who doesn't have type 1 diabetes. In type 1 diabetes, now if you'll recall from your anatomy physiology days, the pancreas has islets of Langer, stop it. Islets of Langerhans in the pancreas are responsible, the beta cells responsible for producing insulin. In type 1 diabetes, that doesn't work. The beta cells, the islets of Langerhans in the pancreas, don't work. They don't secrete insulin. Type 1 diabetics don't have insulin. Type 2 diabetics do have insulin. It just doesn't work very well. If you'll recall, the purpose of insulin, secreted by the pancreas, and it secretes insulin at different times during the day based on when you eat. One of the words I need you to understand and remember is prandial. The word prandial means eating. So if somebody is postprandial, it's after a meal. They have just eaten. Preprandial, they haven't eaten yet. Insulin is released from the pancreas. I should have drawn my little pancreas here. Let's say that this is your pancreas, and you remember your liver kind of sits up here, and your pancreas sits right underneath there. It's sort of like this lumpy little long tubey shaped thing that sits right up under the liver. And you've got a common bile duct and the pancreatic duct, which come together over here. And after you eat, then the body recognizes that there's food in the system, and typically, you know, sugar from most meals. And so the pancreas releases more insulin into the bloodstream, and insulin then is the transporter for glucose to get to the cells, because all the cells in all the body needs glucose. That's the fuel. So the whole point of the insulin is to, this is supposed to be like a little car. I don't know if you can see it from there. But you'll remember from talking about fluid and electrolytes and osmolality, you know that you have glucose floating around in the bloodstream. and it sits around out here on the outside of the bloodstream. Normal blood sugar, blood glucose, dextrose, sucrose, those are all forms of sugar, same thing. Normal blood sugar, which is a combination of any of the sugars, should be between 80 and 100. The best way to determine somebody's blood glucose level is fasting. So they should be fasting for at least 12 hours. And then that number should be between 80 and 100. If you get a casual blood glucose, so somebody comes in and you just, they've been eating, but you really need to know what their blood glucose is, you can still get a blood glucose, but it typically should be less than 200. If you get a casual blood glucose and somebody has just eaten and it's greater than 200, that person is probably diabetic. If you have a fasting blood glucose that's greater than 126 or 130, that person is probably diabetic. So anyways, normal blood glucose should be between 80 and 100. And the purpose of insulin in the bloodstream that gets excreted by the pancreas is to pick up the glucose and put it into the cells, where the cells can use it as they metabolize and do what the cells do. So that's just a little refresher. You should have remembered that from your physiology and pathophysiology days. Somebody who has type 1 diabetes, the pancreas is just not secreting insulin. So they have all this glucose in here, but they have no way to get the glucose into the cells, into where they need to be. So the symptoms that you'll see in a patient that has type 1 diabetes, typically it shows up in childhood. Children, usually around the age of 5, 6, 7, sometimes as late as 12, will start developing symptoms of type 1 diabetes. The symptoms are important to recognize. So it's usually in children, they will have polydipsia, meaning they're very, very thirsty. The reason they're thirsty is because they get a ton of glucose in here, right? And do you remember what that state is called when somebody has really high solutes? The patient becomes hypertonic or hyperosmolar, less water, too many solutes. And that will send a trigger to the brain, I'm thirsty, because the body is craving water to try to restore equilibrium. So that's why your patient has polydipsia, poly meaning many, dipsia meaning thirsty, very thirsty. Another thing that your patients will start to have is polyuria, poly meaning a lot, uria meaning urinating. They urinate a lot. The reason is because there is such an abnormal osmolality in the bloodstream when it hits the kidneys. Now you remember down here in the loops of Henle, you have varying osmotic gradients down in the kidneys. Well, when the blood that's full of glucose, way too high, hits the kidneys, because of the osmolality difference, it starts spilling sugar. So sugar then will gets drawn out of the bloodstream, and water will follow it, making this situation worse. Which is why it's like this perpetual cycle where they're really, really thirsty, but they're peeing all the time too. The other symptom that is pretty classic in these children is weight loss. Even though they have a voracious appetite, they're very, very hungry all the time, but they're losing weight. The reason is you need this glucose to get into the cells to actually be used. If you don't have the glucose in the cells, it has to then go into anaerobic metabolism. It's not getting proper food sources, proper glucose. So the patient then will start losing weight, but they'll still think that they're very, very hungry because of lack of fuel, basically, to all of these cells. This is, by the way, this is a GI tract. This is large muscle groups, but all of your organs, all your cells need glucose in order to function. So if you see a child starting to present polydipsia, polyuria, increased hunger, at weight loss, and especially with if they have a family history, ask them about their family history. Does anybody in the family have type 1 diabetes? And then you get a blood glucose. If that blood glucose is high, like I said, either greater than 126 or greater than 200, depending on if it's a fasting blood glucose or not, the patient probably has type 1 diabetes. Now, it's not going to do you any good. If you have a patient who is exhibiting these symptoms, it doesn't do you any good to ask them if they have type 2 diabetes in the family, because those two things are not related at all. It's like if somebody comes in with cancer and you said, oh, does anybody in your family have had heart issues? That it doesn't correlate. So you got to keep in mind that those are two completely different diseases. So these are the symptoms of type 1. Typically, these symptoms come on fairly quickly. The patient will start having these kinds of symptoms, and usually within a couple weeks, it's diagnosed that the patient has type 1 diabetes. Type 2 diabetes is quite a bit different. In type 2 diabetes, the pancreas still releases insulin. The pancreas still produces insulin, but it's not very effective. So, and the receptors are less sensitive to it. So, and this occurs, it can occur for a couple of different reasons. Some people are just genetically predisposed to developing type 2 diabetes. If they're not overweight, they tend to develop this later in life. Somebody in their 50s or 60s, and they might not even know they have it. They would go in for like their physical exam and then find out that their blood sugar is high. So typically when your patient goes in for their physical exam, and they're often taught to have fasting labs done. So those, if you're going to the doctor, they'll say, okay, don't eat for 12 hours before your blood work. If that first blood sugar comes back and it's a little bit high, typically what they'll do is wait, depending on how high it is, anywhere between a couple weeks to maybe a month, and then retest it to see if that blood sugar is still high. If it is, then the person probably has type 2 diabetes. So type 2 diabetes still has insulin production, but oftentimes it's not enough, or it is ineffective in getting into the cells, or there is a resistance to the insulin. So even though there's insulin in the bloodstream and glucose in the bloodstream, it's kind of like, remember how I drew my insulin as a car, as a transporter for the glucose? You can kind of think of it as like this little glucose is also like, yeah, I'm not going to take that ride. I don't want to get on the insulin. You can go do your thing. I don't want to do that. So then the blood glucose levels start going up in the bloodstream because of a decreased resistance to the insulin, even though there's still insulin there. One of the huge contributors to type 2 diabetes in the United States is obesity. In the face of obesity, where people have been living with high levels of fat for a long time, the high levels of fat tend to contribute to decreased insulin production and decreased sensitivity to the insulin that is there. And this type 2 diabetes tends to come on much more insidiously, and by insidious I mean it creeps up without the patient knowing it. They might occasionally be a little bit more thirsty, just if the glucose levels get too high, but they don't have like the weight loss, they don't have like all that kind of stuff that a type 1 diabetic would. So that's typically found on physical exam when they draw blood. So that's really important to know the difference between type 1 and type 2. Now, so how do we determine, oh, and there's one other that I want to point out. You're going to go over this a little bit more when you do your OB rotation, and it's called gestational diabetes. Some women, when they are pregnant, will develop gestational diabetes, meaning that they have higher than normal glucose levels just during the time of when they are pregnant. Typically, during the pregnancy, and I believe it's in that first trimester of pregnancy, they will, most pregnant women will have a glucose challenge test where the mom has to drink a high sugar content, wait for an hour to 4 hours, something like that, and then come back and have their blood sugar tested to see if they're developing gestational diabetes, because in the presence of high sugar content in a non-diabetic patient, the receptors in the bloodstream will send messages to the brain, which send messages to the pancreas to secrete more insulin. So, because basically what you're doing when you ingest a high sugar meal, you've just dumped more glucose into the bloodstream. Well, in a healthy functioning pancreas, the pancreas recognizes that there's more glucose there, and it will send down more insulin. This is why you have variations of insulin throughout the day, because it is based on hormones and how the food, like a meal. So if you all of a sudden have more glucose in your system, like, you know, go have a hot fudge sundae, you're going to have more glucose in your bloodstream, then the pancreas recognizes this and then sends in more insulin. So basically, you just called a bunch more Uber cars to come pick up the glucose, so that then the glucose can start, you know, going into the different organs. This is exactly why somebody who overeats, eats way too much sugar, they start getting fat, because now you're getting way too much glucose in here, and it'll just get stored. It just gets stored out here in these systems, typically in the way of fat. So that's how a normal person would have more insulin in the presence of glucose. And then these women that are pregnant can develop gestational diabetes. Now, oftentimes after they deliver the baby, then their diabetes goes away. But if they are diabetic while they're pregnant, then you have to kind of monitor that, the mom, a little bit more closely. There's another condition called prediabetes, and that's somebody who comes in and they're kind of toying with these blood sugar levels, like between 100 and 120. It's just somebody that you watch, because they could be developing insulin resistance or reduction in insulin production. So you kind of watch that person, and we call it prediabetes. And then you would want to implement things to avoid developing the type 2 diabetes, and that would be things like a healthy diet, exercise, lots of water, things like that to help improve the patient's overall health, so that hopefully they don't develop the type 2 diabetes. Oftentimes patients who are overweight and they have been diagnosed with type 2 diabetes, if they lose weight and get healthy, the diabetes will fix itself. And that's always the goal. So if you're talking and doing patient education with somebody who's overweight and they are diagnosed with type 2 diabetes, with these high blood sugars, if you can get them to eat healthy, avoid sugar, start exercising, get rid of the excess fat out here, then oftentimes the disease will reverse itself. And that's obviously always the goal. Okay, so let's look at your book. I already told you a lot about the first couple pages here, where it talks about type 1, type 2, gestational diabetes. We already talked about that. And prevention. So, let's see, do I want to tell you anything else? Yeah, impaired glucose tolerance, meaning they don't tolerate the glucose very well in prediabetes. Oh, I know. Also in complications, and this is in the first couple pages of your book, they talk about some complications like end-stage kidney disease, retinopathies, that kind of thing. We're going to talk about that in the third video that we do. let's see. Oh, I do want you to know chart 51.1 on page 1417. That's a good chart. It shows the risk factors for developing diabetes. So yeah, down at the bottom, chart 51.1. That's a good chart to know, just to keep in the back of your head, so when your patients come in, you have a pretty good idea of who might be at high risk for that. The other thing that we're going to talk about, and we can talk about this more in complications, is this notion of DKA, diabetic ketoacidosis, and that's for type 1. Your type 1 diabetics only have DKA, diabetic ketoacidosis. Type 2 diabetics can also have very high glucose, and that's called hyperglycemic, hyperosmolar syndrome, and we'll talk about that, and that's for type 2. So DKA is type 1, and HHS is for type 2, and we'll they kind of have the same like the same pathophysiology, but the cause is a little bit different. Let's see, is there anything else I want to tell you, and then we can go into the treatment. Oh, I know what I wanted to talk about. I wanted to tell you about A1C. So if your patient comes in and you find out that they have high blood sugar, then you want to find out, and you've determined that, yeah, they're full-blown diabetic, they're not just pre-diabetic or something, then a really good number, a laboratory value to get, that's even better than your blood sugar. And you guys have probably all done this. If you're working as a CNA or something like that, you get blood sugars all day long, every day. It's super simple. You just get a little drop of blood, and there's all kinds of machines that can tell you what the blood sugar is. There are some research being done now to figure out blood sugar without having to poke somebody. They're making contacts. They're researching this. Making contacts that somebody can wear that detects the amount of sugar in the fluid in the eye, so that can just and then would go to an app that says your blood sugar is X or whatever. So they are starting to do some different testing. There's one that's that they're working on that people can blow into, that'll detect, kind of like a breathalyzer thing, that'll detect how much sugar is in there. So they are coming up with some different mechanisms. Now, the one thing that is an even better indicator than just a straight blood sugar is this thing called A1C. That doesn't work out very good, but okay, A1C. I think my thing is still wet. The other words for it, and it means the same thing, glycosated hemoglobin, glycosated A1C, or just your A1Cs. What that means is, so here's your red blood cell, okay? This is your red blood cell. Red blood cells live about 120 days, okay? So your red blood cells, they are produced in the bone marrow and in the spleen. They get released into the cardiovascular system, and they float around, they do their thing, they carry oxygen, and you know, all those things. They live for about 120 days, which is 3 months. During this 3-month period, as this red blood cell is crevassing through the cardiovascular system, dropping off oxygen, you know, picking up carbon dioxide, all the stuff that red blood cell does, during that time, the outer surface of this red blood cell is getting bathed in all the stuff that is inside the vascular system. So it's getting bathed in all that. And then it sort of leaves a little mark on the wall of that red blood cell. So when you get an A1C, or a glycosated hemoglobin count, what they're doing is they take out a red blood cell, and they're looking at the lining of that red blood cell, and they can determine how much sugar that red blood cell has been hanging out in for its entire lifetime. So if you have a patient that comes in and you're getting a blood sugar, and you might get one that says 100, and you're like, oh, okay, that's pretty good. But then you draw the A1C and find out that their A1C is high, then you know that this person has probably not been real compliant with their regime, because they've had high glucose levels for the past 3 months. Now, when the A1C test first came out, we wanted it to be less than 7%, meaning you wanted less than 7% sugar in the lining of that red blood cell. Now, the ADA, which I would recommend you guys going to look at the ADA's website, that's the American Diabetic Association, their website. It's a great website. When a lot of your patients will be on like ADA diets. That's the recommended diet for a diabetic patient that comes out of the American Diabetes Association. So now the ADA is recommending that the A1Cs be less than 6%. They're just finding that the outcomes are better. That patients have fewer complications and they do better the lower this number is. So you might see some that some labs say they want the A1C less than 7%, but now the ADA is recommending 6%. I can't remember what your book says. I think your book is still saying less than 7%, so we'll use the 7% for our purposes. But definitely when that A1C is getting up over 8%, 9%, 10%, that red blood cell has spent its entire life in a bath of sugar, and it doesn't like that. So that's a problem. And when your patient's A1Cs start getting too high, then that's when you're going to start seeing all of the other complications that come from having blood glucose levels that are way too high. So some things that you want to do, you want to watch your patient's BMI, their body mass index. You want to keep it less than 25. Your patients that are starting to have BMIs, body mass indexes, greater than 26, they're getting overweight. And your patients that are overweight now are at risk for developing type 2 diabetes. Even a little bit of overweight, even somebody that's like 10 to 20 pounds overweight, as a higher risk of developing type 2 diabetes. The other thing that's really important for all of your diabetic patients is to not skip meals. The reason this is important is because of this release of insulin from the pancreas. If these glucose levels get too low, then the person can become hypoglycemic, meaning less than 80, and that's not good either. When a patient gets hypoglycemic, they will get sweaty. You've probably all had this. This happens a lot, like if you haven't eaten for a while and then you have, like, let's say a Snickers bar or something that has really high sugar content. It releases the insulin. It quickly rushes at these simple sugars, and gets it, out of the system, and then like an hour or so later that the blood sugar plummets, and then the patient gets shaky, the heart rate kind of goes a little bit fast. That's because of hypoglycemia. Hypoglycemia is common in your patients with diabetes, especially type 1 diabetes, and you need to know how to counteract that. We're going to talk a little bit about that during the treatment, but it is important. So if you get somebody's blood sugar, even a casual one, and you're finding that that's like in the 40s or 50s, that patient now needs more sugar. And then usually we teach our patients, to the type 1 diabetics, to have some hard candy available. Jolly Ranchers are good, or some apple juice, not diet apple juice, like regular apple juice that has high sugar content, that they can reestablish that glucose very quickly. So you do need to be aware of hypoglycemia as well as hyperglycemia in our patients who have diabetes. And that's why not skipping meals is very important. It is really important in our patients who are diabetic that they eat as soon as they get up, and that they have healthy, well-controlled meals, like nutritious whole grain breads. The pyramid, the ADA recommended diet with the whole grain breads, lots of fruits and vegetables, some protein, but healthy proteins, the salmons, the chickens, beans, those are healthy. And typically low sugar, especially in your type 1, they should not have, type 1 diabetics should not have any sugar. Type 2 diabetes can maybe have a little bit of sugar, and this becomes a problem, especially in type 1 diabetics, because if you recall, I just said the type 1 diabetics develop the disease around the age of, late school, so like 8 to 12. So your patient who has just developed type 1 diabetes when let's say they're 12 years old, and they're learning how to live with this, because the type 1 diabetics have to give themselves insulin because they don't have insulin. So now they're learning to give themselves shots. They might have pumps or things. We'll talk about that a little bit later. And they're learning how to eat and stay healthy. The other thing is when you go outside and exercise and play, you're demanding more glucose from the system. So they also need to be taught to check their sugars before they go out and do sports or go out and play. Well, if you will recall, maybe you haven't gone through this yet because you haven't had peds, but right around the age 12, this is when adolescence starts, and the big developmental process going on in the adolescent brain is peer group. They want to fit in, they want to be like everybody else, they want to do what everybody else is doing. Well, now all of a sudden everybody else is going out for cake and ice cream to celebrate Johnny's birthday after the big win at the football game. So now what? Now this person can't eat the cake and ice cream. They can't hang out with their friends while they're all having cake and ice cream. And then it gets even worse as they move into young adulthood and college life, when now everybody's going out for beers and alcohol, and alcohol is very high simple sugar content. So as soon as you ingest alcohol, you have a ton of glucose. Well, if somebody who's type 1 diabetic has to be very, very careful. So what a lot of them learn to do is to inject more insulin and then still go out and party with their friends, and it becomes very detrimental, and the complications from that can be significant. So factoring in where a person is at their developmental stage of life with this disease, especially in type 1, it becomes a very important nursing piece. Okay, I think that's enough for this part of the lecture because I know it's a lot. I'm going to let you sort of ingest this, read the first couple pages of the chapter. I'll stop this video and then we'll come back and we will start in on some of the treatments and drugs for the patient that has type 1 and or type 2 diabetes. Okay.